Right, it's 1 minute past now, so I think we will get going. So welcome everybody today to our webinar on how we can achieve excellence through research engagement. I'll put my camera on so you can see who I am. So my name is Nicola Verstralen. I'm the leader of our community of practice, and we have many of the group in here today who are part of our steering group. And as you can see, all the photographs of our group. Do you want to just pop yourself on mute, whoever's not got themselves on mute there? So really excited today. I think we might even have colleagues from America in the house because they are really looking forward to hearing one of our speakers in particular who's published internationally. So do you want to just move on to the next slide? And I'm not going to go through everybody, all the speakers can introduce themselves, but if you just go on to the next slide. Just a reminder of where we've come from. So our community practice is all in relation to the Matrons and Health and Care Leaders Research Toolkit. And part of that resource, we have a Futures NHS webpage where a number of the things that we might talk about today are embedded amongst that Futures webpage. And these webinars are part of that package as well. So don't forget to register for that Futures webpage. Next slide. So I'm really pleased to announce we've got Professor Annette Boaz with us today, who's going to frame the webinar around all of the research that she's done on research active organisations and the benefits of that. So welcome, Annette.
Thank you, Nicola. It's really great to be here. I'm really looking forward to this session. There's loads of great things. I've had a look at the slides. So I'm going to talk a bit about the research that we've done. I look after an NHR policy research unit for the health and social care workforce, but I also have an interest in how we build capacity for research use in the NHS and also more widely in social care. And I'm going to draw particularly on a substantial kind of review that we've done and then more recently updated to try and get a handle really on the evidence around whether it makes a difference. I think we've lost the slides, or I've lost the slides.
Brilliant. Sorry, I don't know what happened there.
Can we have the next slide, please? And the next one. So actually, Nicola shared a more beautiful slide around the work that you've been doing, many of you in your community of practice, around all the different things that we do within the NHS to build capacity to engage with research. And this, I've got here an example of the career pathway, which very much focuses on individuals and their own personal development, but you have on your visual lots of other really interesting and exciting things that are out there to support building a research culture. What I guess we have had problems evidencing in the past, particularly in the UK context, is whether this really makes any difference. We spend all this money on research. We have an intuitive sense that this builds better organisations, better processes of care, better outcomes for people using services, but we haven't really been able to evidence that. Next slide, please. What we have been able to do, and this is a more recent piece of work that we've done trying to take ideas from the NHS and particularly from hospital settings into general practice, is we have been able to see that research activity has beneficial impacts on individuals. So it makes them often feel more satisfied in their research careers, has a little impact on things like retention of staff well-being, and a kind of general sense of people having an opportunity to explore and develop their practice. So these are great outcomes, and it's really positive that we also see those coming through where we've sought to build research capacity in primary care as well. But this isn't really the end game of the NHR's investment in research. So really good and positive outcomes to be able to see, but does this really make a difference for the service? Next slide, please. So we have had many kind of policy documents. This is one from the Academy of Medical Sciences that have started to kind of draw on the bits of evidence that are out there. And this includes this quote that says, "There's a growing body of evidence now that patients in health-active healthcare settings, research-active healthcare settings, have better outcomes with benefits extending to patients beyond those actively involved in the research." And that's a really important distinction I just want to draw at this stage about the work that we've done. This isn't about the benefits for people who are directly involved in things like clinical trials. This is about benefits that go much more widely into the organisation, maybe through those organisations participating in trials, but we're seeing benefits that go beyond does it help patients who've participated in trials, a much wider organisational impact. And so back in 2020, they were pointing to a review of ours from 2015, and then a number of studies, so by Amy Downey and colleagues from, in particular, that had started to look at this in the NHS context, and particularly looking at the impact of the NIHR's investment. So the Downing work is looking at investment in clinical research networks, for example. So starting to feel a bit more positive that we're seeing this effect. And when we sort of saw this, we were just in the process of updating our review from 2015, which had seen kind of positive indications that this was the case, that all this research investment was making a difference, but almost exclusively drawn from outside of the UK, primarily, as with any of you've done, a kind of systematic reviewing coming from North America, from a very different healthcare system. So we thought it maybe was timely to update our review and to particularly see whether there was any more evidence coming through that this was making a difference for us in our NHS context in the UK. Next slide, please. So this is the summary slide of what we found in the review. I guess the first thing to note is a huge growth in the evidence out there and the quality of the work that people are doing. So people have worked really hard and to try and see whether it's the research investment that's making a difference. As you can imagine, anyone who's designed research studies, it's really hard to distill a factor like research engagement to see whether that's the factor that's really making a difference in organisational change. But we see people working really hard to be able to do that. For example, looking at what they describe as a dose effect of research. So if you have more research going on in your organisations, you get even better outcomes. So trying to work around the very difficult issues of attribution to see whether this is a real thing or maybe just a symptom of something like having teaching going on in your hospital. And we do see that it's about the research engagement and research investment, not just about kind of building teaching hospitals, which actually have kind of rather mixed outcomes. So what we see here is a largely positive picture, which is really good. We see the positive impact of research networks, which I'll talk a bit more about in a minute, and other collaborative activities, and the importance of more engagement, getting more benefits. And really importantly, we see that spread. So there's a health equity dimension here. This isn't just focused in a few centres of excellence. We see this across environments that people are working really hard to make sure the benefits are felt beyond small pockets of high research activity, but across the healthcare system. And actually what we have just very quickly to note, the things we have flagged as negative here don't necessarily mean bad outcomes from research engagement, but they mean, for example, one of the studies is looking in an area of kind of asthma guideline in implementation where the level of implementation is so high that you don't see any upgrade from kind of building a research culture around that. Next slide, please. And next slide, I'm not going to focus on this. Thanks. So I'm just going to pull out a few things before I finish. So the first is that we see kind of some interesting examples of what these improvement mechanisms are. So what is going on in the system to get these better outcomes for patients that are so good to see? So what we see is strong evidence-based protocols. So, for example, those of you who are involved in kind of supporting clinical trial work in hospitals. So those strong evidence-based protocols that are developed as part of RCTs can be seen to contribute to wider healthcare in those organisations. So people take those protocols and they apply them more generally, and protocolized working spreads more generally in the organisation. And then we see some really interesting mechanisms that are at the kind of speciality or clinician level. So this is particularly multidisciplinary team working, skill development in particular areas. So we see things that are about how people work with their own clinical team or with speciality, and bringing people together and sharing those expertise and that research knowledge, really benefiting the system. And then the final one I've just pulled out is about kind of consistency, particularly around guideline intervention. When I first started working, people assumed that if you had a guideline, that would lead to practice change. We know that's not the case now, but actually if you're building this culture, then you see you've provided an environment where these guidelines can actually be implemented, and you build this kind of culture of excellence around that. Next slide, please. But probably the thing that next slide, please. The thing that comes out most strongly is around networks. So the importance of networks, and you are an example of one of those. People coming together to learn, people sharing. Can I just move this on? I'll move it on, can I?
Sorry, I think
has it stopped?
The person that's sharing, Nick, her computer's just crashed. So is there anybody else that can share?
I can try, Nick. Just pulling up now. What slide are you on?
The one about networks, so the one after mechanisms.
Right, let me share. Let me know if you can see that.
Perfect. Yeah, if you could put it into slide view, that would be great. No, sorry, it's one back front, or two back actually. Is it back? Maybe. No, that's fine. That's fine. I'll come on to the.
Shall I, where it was?
If you could go. This doesn't look quite right. Yes, that's perfect. Thank you. So research networks come across as the most powerful dimension. I thought this would be particularly interesting as a network yourself. And we see lots of work that's been done on this, and including work on the NHR in the UK, so the NHR's investment in networks. Some of this has been going on since the 1980s, particularly in the US. So there's something about what we do together as networks, how we learn together, how we share learning, how we share best practice, how we share thinking, and how we do that together in an iterative way that's really powerful. And it's probably the most significant stream in the literature that we found. So this idea of, if we're going to build this research culture, all the bits are important. You know, the doing of research, the guidelines, the protocol-based working, the teams, but the networks which connect us out of our organisation with others and into the system more widely seem to have this amazing benefit. Next slide, please. And this also has implications for equity, actually. People have used this network model to make sure that things don't get stuck in centres of excellence, but spread out much more fully through the system. And next slide, please. So just to finish up some takeaway messages, just so we see such a strong evidence base now in this area, for just really significant body of knowledge that we can feel quite, that we can rely on, and that contains a significant amount of work from the NHS in the UK, so that about the work that we do and the engagement we have within the system. That the networks are such an important part of that, and I think it's really important to restate that, because networks are often things that are hard to fund. They don't cost a lot of money, but to keep that investment in networks is really important. But what we see is kind of this, what we've seen described as a dose effect. So the more research engagement we can build, the better outcomes we get. I was talking to a PhD student the other day who thinks that there might be a tipping point of that. You know, you might get to a point where that's optimal, but we're nowhere near that yet. So that idea that, you know, of a dose effect at the moment is really important. And this is really about not just about getting that money into sense of excellence, but also really the equity lens works here. So people are really interested in spreading this learning out, making sure that this is for everyone. And after all, that is a real ethos of the NHS, but also of NHR's investment. And I just however, wanted to finish on a bit of a note of caution. Next slide, please, which is just that this takes a lot of work. And this is some work we did some years ago now about what it means for professionals when they get all this brilliant extra training from NHR, and it helps them grow as individuals. We need the systems and cultures it sounds like you're working on to really absorb that knowledge and use what those people have learned. And what we found back in this study we did in 2020 was actually people finding lots of resistance from their managers, from their colleagues, and from their organizations to using all this brilliant new knowledge and skills that they had. So really the importance of keeping working on all the different elements that sit together to build a culture that supports research use and gets us those better outcomes for our patients. Thank you.
Thank you so much, Annette. I feel as though I'm so privileged to have you today because, you know, since I've been working in research, I've been quoting your paper forever, that we need to promote that research embedding across the clinical systems. And you're exactly right. The summary that you had there is, I'm sure everybody that's here today, we all want to do it. We all know that it's important. It's just how we move it forward, isn't it? And so that's what we are trying to do, trying to help people to give little different clues, stimulate ideas on what other trusts are doing, and see if you are able to implement some of that in your own scope of practice as a leader, but also, you know, across your department, you know, really delve deep thinking about your evidence-based practice and your evidence-based care, and are you delivering that? And you know, when you have patients that are on your clinical areas that are on trials, you know, they've got access to that 24-hour care, that extra level of care. So yeah, hopefully we can help as we move forward to stimulate some of those ideas. Is Nick back?
I am. Sorry about that.
No worries, that
had
happens.
a funny 5 minutes and just threw me out and shut down, but I'm back. So
are you able to share again, if that's all right?
I will try to do that again.
Thank you.
Is that sharing?
Yes, brilliant. Thanks very much. So I'm going to welcome Janette. Going to welcome Janette and Tania now, and if you could introduce yourself, that'd be brilliant. If you just move to the next slide. Thanks, Janette.
Thanks, Nicola. That's great. So thanks for having us. I'm not quite sure how we follow Annette's presentation, but we'll give it a go. So this is about how we're really trying to embed research across our system within our organisation at Manchester University NHS Foundation Trust. So my name's Janette. I'm the Assistant Chief Nurse for Research and Innovation, and my colleague Tania Bakhat is here as well, and she's our Matron for Healthcare Transition and the MFT Youth Service as well in our children's hospital within our trust. So we've been asked to present our work on clinical accreditation and quality assurance, and how we've managed to get research embedded within the process within the organisation. And then Tanya's going to talk about some real good tangible examples of what she's done to really embed it. So I'm going to do the overview and then she's going to do the good bits. Okay, so next slide please, Nick. So just to set a bit of the scene really, so accreditation is part of our trust assurance mechanism. Like many of you, you'll have this across your organisation, and it's there to ensure high quality care and the best patient experience. And our process is underpinned by three main things fundamentally. One is our IQP, which is our Improving Quality Programme, our trust strategy, and then we also have an MMAP strategy as well. And what's really important is that the process aligns with our CQC key lines of inquiry. So we're looking at the domains of caring, responsive, effective, well-led and safe. And there's three themes that this sort of groups around, which is patient experience, patient safety and clinical effectiveness. So this is the process that we have across our organisation. Next slide, please, Nick. And so what happens is that each ward or unit or department, and it originated many years ago now that it was just ward based, but eventually it's gone out to all departments. So for example, in R&I, my clinical research facilities are also part of this accreditation process. And traditionally, well, historically, we didn't have research embedded in the accreditation programme. And eventually, over over the last few years, drip by drip, we've managed to incorporate it further. So the accreditation process, first of all, starts with the accreditation portfolio, and the ward unit or department are responsible for completing this portfolio. It then also looks at the data pack. So we look at this is the data that we're going to triangulate with what we see from the portfolio and the actual visit. So it's the quality dashboard. We've got the quality care round data, the what matters to me, the harm-free care data, workforce and health roster as well. We're looking at complaints, incidents, any PALs that are coming through, student feedback, our friends and family, HR data, etc. So all the data, definitely data driven, which is where we want it to be, but all this is triangulated then with an actual visit. And on the visit, we review this data. It's an observational visit led by a senior nurse within the organisation, and then another couple of either a matron and a lead nurse and someone from the quality improvement team. And we review the findings and we complete the key lines of inquiry calculator as well. Next step, please. Next slide, please. Thanks, Nick. So, so these are the questions that are part of the portfolio. And for us, this is just fundamental, yeah, because the ward or department or unit have got to look at this and have really got to dig deep and think, right, how are we demonstrating this? So these are the questions that we're asking. So for example, you know, do proposals include discussions about research? Do you have a research notice board? Do you provide an overview of the current audit? So we're trying to incorporate audit and research. We're very mindful that a lot of colleagues start with IQP projects, then move on to audit, potentially service evaluation, and then research. So this is what they've got to start looking at. And this has been new in our accreditation portfolio in this financial year. Next slide, please, Nick. So what we then do on the actual visit is talk to staff and talk to our patients. So what's actually changed is that we're going to we actually ask the manager, the staff member, but also the patient, have you been given the opportunity to take part in research? So under the different domains, so for example, clinical effectiveness, we ask the manager and staff, do they understand the importance of research? And that generates a conversation, and you're using your professional judgment as that member of the accreditation team to actually score where you feel that that area is. Are they able to articulate any current research relevant to their area? Do they understand about research that's relevant, and can they provide evidence-based practice as well? Is it discussed at appraisals? So they might say it in the portfolio, but actually, are you triangulating that with what your staff are telling you, what your manager's telling you as well? And have healthcare professionals discussed or provided research? Are they provided with research opportunities as well? Next one, please, Nick. So this is how it's then looked at. So we scored in our accreditation from gold, which is outstanding, all the way down to white, which is inadequate. And that's aligned to the CQC standards. So you'll probably all be familiar with this. So the first three rows, the exceptional, standard care, and the follow ones down from there, that's what's looked at, and that's how we score them. And then the last row that we've put in there is how we're scoring it from a research perspective. So from a white in the bottom right corner, if no staff are able to articulate what research is taking place in the area and why is it important, they will score a white on that. And gradually you can see increments up to be able to get in a gold, where 3 out of 3 staff will articulate why research is important. Use evidence of communication of the research findings, because you might have a research board there, and you've got evidence of a range of staff being involved in it as well. So you can see that we're trying to score it in line with how we would score patient experience, and looking at the harm-free care work as well. And you know, and I'll be really honest with you, if we took a baseline now, most of our areas are probably coming out maybe white or bronze, but actually that puts us in a really good position then with the work that Tania's doing, for example, because what it's making us do is really hold that mirror up to see where we sit as an organisation, but really to start moving forward then as well. And it's initiating a lot of conversation. So I'll move on to Tania, and she can tell you what she's been doing. Thanks, Tania.
Thank you. So Thank you, everyone. So I am going to talk to you today about how, as a matron, I support ward managers and staff members to embed research and clinical practice. Next slide, please. So as part of the MFT strategy and the organisation's objectives and strategic priorities in delivering MFT's vision, Objective 5 is to deliver world-class research and innovation that improves people's lives. And we can do this by becoming more research active, more research aware, and ensuring our practice is evidence-based. Sorry. So I looked at my own understanding of research and actually realised that I didn't really know very much about research. The last time I even looked at research was when I was actually studying to become a nurse. So I wanted to know more about it. So I undertook a 6-month Health Education England integrated clinical internship that was delivered by NHS Research and Development in April 24. And this internship was an introduction to the essential aspects and roles within practitioner academic research, and it looked at things from trial design and data management through to undertaking research and practice. It provided me dedicated time to enable me to gain a broad understanding of the world of health research and help me to look at whether this was an avenue that I wanted to take further, both in my personal and professional development. And it provided me with a unique opportunity to dip my toes, as it were, into academic research. Next slide, please. So looking at how we would enhance research and capacity, to strengthen research capacity and capability within the nursing discipline, our ward managers have the potential to play a central role in promoting the importance of research in wards departments, and it involves demonstrating leadership skills to champion research as a core component of clinical practice. It utilises their influence to actively engage in MAPS in research initiatives. It promotes the significance of research and its direct impact on patient care and professional development. Embed research into daily clinical practice so it becomes business as usual. It supports research opportunities at all career stages, and it promotes a critical role of research improving the quality of patient care, which is always the key theme of our care, and it highlights career pathways and roles within nursing research, which NMAPs may not have thought about previously. Next slide, please. So, recognising the importance of fostering a positive research environment for NMAPs in clinical practice, I looked at a few ward managers over a 6-month pilot project, which was designed to support ward managers to create and sustain a positive research environment within their clinical areas and departments. So there was a massive gap. Our NMAPs were not getting that information as to how they could get involved with research. So 3 managers from RMCH, the Royal Manchester Children's Hospital, from Ward 84, Ward 79 and paediatric outpatients worked collaboratively with myself, and the aim was to organise relevant information, training and resources, ensure that there were tools that were easily accessible to support ward managers in their roles, and equip ward managers with the necessary skills and knowledge to effectively support and engage their clinical teams in research-related activities. Next slide, please. And just a point also from the previous slide that Ward 79 was a research active ward, so it was very interesting to find out what their results would be after this pilot project. So the kind of information that we supported our ward managers with over the 7 sessions that we did this programme was, did they have a named research champion who would increase research awareness and provide information to other NMAPs? Do they have a research board in use and ensure it is up to date and fit for purpose? The idea was to provide communication and dissemination of research information and NMAP opportunities. The 3rd session was to identify research and IQP projects being undertaken. The 4th session was to identify NMAPs undertaking research specific courses or internships. The 5th session was to identify the number of conferences and workshops or study days that they had attended. 6th session was to identify the number of abstracts submitted or publications published. And the 7th session was to make sure that was research a part of their annual appraisals for their ward and departmental meetings, and were they aware of research questions asked in the ward accreditations, as Janette has previously mentioned. slide. I'm sorry, and the one of the key outcomes, of course, was the ward accreditation to support ward managers embedding research in their areas. Next slide, please. So some of the questions that we asked, or ward managers could ask their NMAPs, I won't read them all out. I think we're going to be sharing the slides, I'm not very sure, but it was looking at research exposure and awareness, research engagement and involvement, research education and delivery, and research as a leader or embedding research in practice. So these are just some of the questions that ward managers could ask their NMAPs and staff members when they're doing their appraisals to make sure that they are involved with research in one way or another. And a lot of them were quite easy, you know, looking at research journals, being aware of their library services, you know, speaking to their research delivery nurses, and things like that. Next slide, please. Now, to understand how ward managers, what their learning needs and objectives for this programme was, we wanted a baseline to understand what information they knew, what they were aware of, and what it was that they wanted to learn. So we asked them to complete this spidergram that you can see. So red meant that they needed some help, yellow was that they understand a little bit, and the green was that they were very confident in their in that session. Next slide, please. So we did these sessions, so we did these spidergrams at the beginning of the programme, at midpoint and at the end. And you can see that the paediatric outpatients in Ward 84, they felt like they needed a lot of support with research questions and with research support. Ward 79, which I mentioned, was a research active ward, actually had a lot of greens, and they felt that maybe they didn't need as much information. But what was interesting was when they did their midpoint, they actually scored themselves less because they actually realised they did need more information. Next slide, please. So by endpoint, all three ward managers indicated that they felt confident in having research discussions with their NMAPs. And as a result of the sessions on research appraisals, the ward managers demonstrated a significant improvement in their ability to support NMAPs in asking research questions during annual appraisals, thereby maximising their potential outcomes for these discussions. Next slide. So throughout this project, the way we supported our ward managers was to make sure that they had a research champion in each ward and clinical area. They were attending monthly NMAP research champions meetings. They applied for, their NMAPs applied for the 12-month Director of Nursing Fellowship course, which taught them all about research. Attend 6 weekly research and child health symposiums, which we've started at the Trust. Attend research conferences, workshops and study days. So we have had other NMAPs doing internships and attending conferences and delivering research spotlight sessions for ward managers, matrons and lead nurses, being aware of their library services and support, mentoring others to support them with courses, and signpost them to other sources such as Catalyst as well. I think that's the last slide. Thank you very much. Any questions?
Wow.
Thank you.
That was absolutely brilliant.
Oh, thank you so much. I feel like I really rushed that. I feel like I could have given you more detail, but I'm aware of the time limit.
Yeah, absolutely perfect.
Oh, thank you.
I wish that you could lead other organisations with developing that, because you've done it absolutely perfectly. You know, and I love your spidergram, because obviously you work in children's as well, don't you? I like that
Yes.
side of things.
Yes.
And it links in a little bit to what I've just put in the chat about the self-coaching for research leadership tool that we've got within our Futures webpage. It's very similar to that, but yours looks a lot nicer with the spiders. But yeah, so I think, did somebody put their hand up to ask a question? I can't see. I think they put it down now again.
There is a message in the chat, Nicola. Somebody's asking, it's Jen Slyson. Tania, would you be able to maybe share the package, you know, the entire package? I know we've got the slides, but if we could have more information about the package that you've developed, Tania.
I can do, yes.
That would be absolutely perfect. We could pop it on our Futures webpage if you were allowing of that.
We can do. I did a report at the end of this programme to work out what went well and what the challenges were and what we can do better. So everything will be on that report, why we started it, the purpose of it, how we got along and what the conclusion was. So I can share that if that helps.
That absolutely helps. And I think I'd love to be able to speak to you outside of the meeting. I know you've got to rush off to do 3 other presentations on other sessions, but I'd love to be able to speak to you about perhaps even doing a bit of a video recording, going through your findings and different things like that, because I think that'd be really useful, to hear it from the horse's mouth of what you've actually done and what the challenges were, and how you've got through those. Yeah, absolutely. I'd love to link in with you for that. I'm just go on, Tania.
As part of my internship, I've been asked to do a poster presentation. So I'm actually going to put this on a poster. I'm not quite sure how I'm going to go about it because it'll be my first one, and I'm going to present at a conference next year at the R&D Northwest. So all the information will be on that as well. So I'll be happy to share that with you as well.
That's absolutely excellent.
And if anybody's got any tips on how to do a poster presentation, please do share.
I'm sure there's plenty of people in this audience that can help with that. For sure.
Thank
I can put you in touch with some people. I've got a question. So what obviously you did your internship and you pushed yourself to develop, some of those skills. What would you say to others, people like yourself, as matrons or ward leaders, as to what the top sort of 3 things that they need to do to try and drive some of this forward?
So as our role, so I'm not clinical. I'm not on the wards, so I do have the time to be able to focus on this. So I am very aware of that privilege. But I will say is, as research should be business as usual. Everybody should be doing it. So do put yourself forward for journal clubs, find out about our library services. I cannot believe how much information I found at library services. Would you believe they told me how to use Google correctly? And I've used it in my personal life as well. So if I want a specific table, I can actually now find a specific table. So, things like that. So do utilize your library services. Do encourage your NMAPs and staff members to attend any conferences. There's so many free ones out there, online and face-to-face. That's how you get started. My line manager, Mary Marshall, I think it was a deliberate act. She sent me to look at some Don Fellows presentations, and that's how I got involved. And I thought, this is something that I can do, because we talk about evidence-based practice, don't we, all the time, but do we actually do it? And I don't think people associate evidence-based practice with research, and that's exactly what it is. So that's how I got started. And I thought to myself, yes, this is something I can do. It's not something people do in labs all the time. So that's what my tip would be. Definitely look at research. It doesn't have to be massive. I'm not doing massive papers. I'm not doing massive projects, but I want to see how we can improve our areas and services.
Again, absolutely brilliant. Yeah, that's something that I've been trying to promote, to really people to think deeply about what are you actually doing around that evidence-based practice side. And yeah, we learn it as we come out of university, don't we? But then obviously the sort of day job sort of takes over, doesn't it?
Absolutely.
But we still need to be able to deliver it. And I think you're right. The word research bit sometimes kind of gets missed because it's research evidence to inform. So yeah, I think that's a great answer. Does anybody else have any questions before Tania goes to her other meetings? Okay.
If anybody thinks of anything else, then do put it in the chat and I'll get back to it as soon as I finish my meetings.
Brilliant. Thank you so much, Tania and Janette. That was absolutely fascinating. Thank you.
Thank you.
Okay, so we're moving on to our next speakers. Have we got Moriom and Rosalie?
Yes, we're here.
Yeah.
Hello, welcome. I'll let you introduce yourselves and go forward.
Yeah. Thank you, Nicola. I'm Rosalie. I'm one of the matrons in intensive care unit at St. Bartholomew's Hospital.
And I'm
Moriom?
Moriom, the other matron at St. Bart's Hospital. So I'll start off and then I'll hand over to Rosalie to the other part. Once again, I mean, that was the presentation's absolutely amazing. I'm not sure how we'll top it up. And thank you for providing us an opportunity to share our learning among such a esteemed audience today. What we will do is we'll share a presentation about how we strengthened research capacity through peer review. If I could have the next slide, please. So this started back in 2017 when we had the CQC visit. Basically, under the well-led domain, we didn't have enough evidence on quality improvement or research, which led to a trust-wide action of promoting QI project. We still have something called First Step training, which is accessible to all staff members across the trust. We have something called We Improve, which encourages staff to work together to provide best patient care, evidence-based. And the trust is also supporting research in practice and clinical academic roles. So at the time, we didn't have established water accreditation program. We still don't. It's work in progress. So hence we decide to use the peer review. Next slide, please. So peer review. We had 3 steps to our peer review process. We use the well-led domain to do our self-assessment to see where we need to work on and where we're doing okay. We had help from the quality improvement lead to help us organize this. We invited internal and external reviewers from within the trust, and we set a date for the review. We got the staff and the ward ready for it. On the day of review, which was the day of inspection, we had 9 reviewers who basically teamed up as 2, so they were able to speak to staff on their own, patients, managers being us, and inspect the environment. At the end of the report, we all sat down and they gave us verbal feedback on what was well and what we needed to work on. Followed by that, we had a written report and we had to develop an action plan on the areas of improvement. So on the following slide, you'll see our outcome. If I could have the next slide, please. So this is our peer review outcome report. So basically, we were able to demonstrate excellent learning culture and the use of research and quality improvement and innovation. So this is our format that we had used. I'm now going to pass on to Rosalie, who will tell you how we evidence that. Thanks, Rosalie.
Thank you, Moriom. Next slide, please. So, it's slightly different from the ward accreditation we provided. Just a different format, basically, of how we assess our unit in identifying the culture of research. So we provided them with the evidence about the number of audits that we have completed. So we've got loads and loads of audits that were done in the department or in the wards. And we've utilized all these audits to identify and prioritize which will be the focus of QI and research in particular. So we use, we kind of link research with QI projects closely, because obviously some people felt like, oh, research is very academic, but in fact the use of research evidence is very important in clinical practice. But we also link that into quality improvement projects so that we can easily translate research into clinical practice at the same time. we've encouraged people, our staff in particular, to develop innovations, research, and quality improvement projects. So those are just some of the examples. And in fact, as of this time, we've got 69 quality improvement listed in our spreadsheets that we have been doing in our department alone. As a result of that, we've developed our governance for a QI in place to avoid repetition and prioritize the most important projects that we need to do, and of course to promote collaborations among the multidisciplinary team. So we have the MDT with representation from different group of specialty to be able to help us and guide us review all the QI projects and research that we are doing in the department. We've also encouraged staff to develop innovation. As an example, we, as a result of the high incidence of surgical site infection, our team has developed the BART surgical infection risk tool, which is currently now adapted in other cardiac centers as well in identifying high-risk patients in developing SSI. As a result of that as well, we've also developed a cardio-adjustable thoracic support vest, which is now awaiting patents, and these are all led by our own staff. Next slide, please. Through the peer review process as well, we were able to feed back the importance of obviously translating research into clinical practice. And because of the involvement of our clinical staff, we were able to recently utilize one of the clinical study or randomized controlled trials that we've been engaged to and translate it into clinical practice very quickly. So I'm very proud to say that the translation of this, which is the tight case study, and now we've done the Relax K quality improvement project, and led to the translation of research to clinical practice from 17 years to just 1 year. And this is because the staff have been involved in the conduct of the study up to the implementation of the result in particular. As a result of that, because of the increase in the awareness of research awareness and quality improvement awareness in the department, we were able to support multiple randomized controlled trial. And as of this time, we are supporting almost 15 randomized controlled trials, both portfolio and commercial studies within our department. And some of them are already being run by our own staff. We've also supported associate PI schemes. So far, we have 7 staff who have completed the associate PI schemes, and more have registered to do the associate PI scheme. And interestingly, I just had a meeting with some of this research lead in other trusts yesterday. We didn't have to pay them to do the associate PI scheme, and staff are actually willingly happy to do it on their own time, as long as we provide them the appropriate support, particularly providing them the high quality randomized controlled trial that they can be engaged to. And I'm very proud to say that we've also run the first nurse-led randomized controlled trial as SPH, which is the wound imaging software and digital platform to detect and prioritize non-healing surgical wounds, which is focuses on the use of AI in wound surveillance. Next slide, please. So as a result of the most recent peer review feedback, we were able to start to embed research into clinical practice, but they've also identified that communicating and sharing of all the activities that we're doing were identified as something that we need to improve as well. So most recently, we have started doing the research newsletter so that we can summarize to them all the activities that's happening in the department. We've made use of our research notice board. We've established our research champions because we realized that obviously we need people to be able to lead the project together. And we've also established the Research Cafe, which is a bi-monthly sort of webinar type of thing wherein we allow people to come together to be able to talk about research and discuss any research questions that they have on a day-to-day basis. We're also planning to establish or to have our first protocol club as well, because we felt that obviously we have our own journal club as well, but then we felt that in a more practical side of things, nurses needs to understand, or the nurses and allied professional needs to understand the practicalities of delivering research, and therefore the use of the protocol club will be able to help us to do that. Next slide, please. So in summary, peer review process offers a mechanism of for self-regulation, and I think this is very important, in particularly for those trusts who don't have the ward accreditation yet, because it also ensures objectivity, credibility in professional work, and contributing to the overall organizational improvement, particularly in the use of research in practice. For us in particular, it helps us improve the quality of care we provide to our patients. It enhances professional development and increase patient safety and satisfaction. Thank you.
Again, wow. Oh, just in awe of everything that you've done there. Just obviously working slightly differently than the ward accreditation, but just doing it anyway. It's just absolutely brilliant. Well done.
Thank you.
So I've got a couple of questions. I'm really interested in that protocol club. I really want to hear more about that. And whether you welcome any external people to your protocol club.
Absolutely, yes.
That would be really good.
Yeah.
Because as an example, Chris, who's on the call, set up the journal club as part of one of the studies, the magnet study that she was running with the hospital in America. So it's a transatlantic journal club. But that would be nice to think about a transatlantic protocol club. But yeah, I think you're right. A journal club is obviously brilliant because you start to understand, you're critiquing what the evidence is about.
Yes.
But when you want to take that action to moving it into potential research studies, that sounds brilliant. So yeah, I'll wait to get the invite to see us joining your protocol club. So I've got a couple of the questions. So obviously you've not got research on your ward accreditation yet. So how are you going to continue to grow this? And is it just for your intensive care area, or is this also across the rest of the hospital?
You want to answer, Moriom?
I'll let you answer that one.
Okay. Yeah, well, we are still working. We've started the ward accreditation in the ward, so it does not include the special area, i.e. the theater, cath lab, and intensive care. And in St. Bartholomew's Hospital, we've got a really huge intensive care unit. We've got 58 bed capacity ICU with about 300 staff in total. And that's the reason why we kind of work on our own at the moment. So we've been working with, we're lucky that the lead for the ward accreditation is actually our boss, and we're working with him to be able to incorporate the research or embedding research into clinical practice into the ward accreditation. But obviously we've just started the ward accreditation. So we haven't even worked through the ward accreditation process alone.
Yeah.
So that's why it's quite difficult to embed it. But luckily, because of the peer review, and we intentionally invited people with backgrounds in research, QI, etc., into our peer review group so that it will be identified, we can be helped in terms of how we can improve further as a department. And because we're running so much randomized controlled trial, we really needed their support into helping us, embed it and support the staff as well. So
Brilliant. Yeah. Thanks. Chris, have you got a question? Oh, Moriom, go on.
Apologies, sorry, I didn't see the hands up. No, I think Rosie's been quite modest there. I mean, she's had a massive influence there in getting research into practice. I mean, as I said, as nurses, we run far away when we hear research. But since Rosie's been in the post, it's just driven this, and there's been so much engagement from nurses all across and MDT. So, yeah, thanks, Rosalie.
Well done. Chris, you got a question?
Yes, I mean, thanks to all the speakers, that's been amazing. I'm just wondering, really, and it's almost something sort of maybe Annette might have an opinion on, as in her role, which is slightly different to the rest of us who are working in NHS organisations, and sort of based on your work, Annette, around networks. So I am aware that the speakers we've had present are from two very big, well-established NHS trusts with a big research infrastructure, a big research culture anyway, which is still more difficult to get nurses, midwives and AHPs involved in, but overall research is a big thing. And thinking about the government shifts around from hospital to community, and particularly on behalf of any colleagues here who might be listening in from smaller district general hospitals, or maybe even working in the community, how do we, I think we need to make sure that we build up these networks so that we can include them, because I mean, we've got a good library as well. If they haven't got access to a library, so maybe it's something that the Royal We sort of in the NIHR and the Research Delivery Network should be thinking about, making sure that we have those networks that reach out and include the smaller organisations or the wider research setting. Annette, I don't know if you've got any thoughts on that, or anything that you've found in your work.
Just a couple of things. I guess this points to the value of networks and intentionality in networks to be inclusive. So to be reaching out and being as you've been talking in this session about, inviting people to join in and be part of things is a really important part of that. The work we did in primary care, I think, started to show how, some of the difficulties really, because the things that we've typically measured in secondary care to show that this sort of work is making a difference didn't really translate very well over into primary care. And certainly I imagine that would be even more complicated when we're thinking about the shift to the community. So if we want to build there's definitely the same sort of appetite, I would say, in the community. But in terms of supporting it, I think there are a whole new set of challenges. And in terms of evidencing it, a set of challenges there as well. So it's really good to be ahead of that and thinking about the implications, because that, is really an important place to start. As we think about this shift, what's this going to mean for really making sure all the hard work that's been done in the hospital setting, and not without its ongoing challenges, that doesn't get lost actually in that process.
Thank you. No, that's really helpful. Thank you.
Thank you. So we've only got a couple of minutes. I don't know if you want to just flash up the last slide, Nick, for our next webinar, which is on the 16th of October, 2 till 3. Well, it's not a webinar as such. It's more a peer learning session. So again, it's delving deeper into these topics generally, on how managers can support staff to get involved in research. So we're going to have Helen Janisuski and Rosalie that are going to be leading that session. So it's a bit like I always think I'm forgetting the word. I can't think of the word again. I don't know, I've got a mental block in that word. But action learning
sets. Yeah.
We have discussed in the past that we were going to be doing action learning sets, and we're not going to necessarily follow that format. It is going, but it will be facilitated properly. So we want people to come on, and we want people to talk to each other to take this learning to the next level, basically, where you might come on and you might have, a very simple question. It's like, well, how am I going to get a job description through, or how am I going to allow someone to do an internship, or how am I going to get an honorary contract with the NHS pressures that we've got. All these questions we want as leaders to bring into this group so that you can talk to others on how they might have solutions for some of those questions or those problems, or they might have done something themselves, and hopefully we can pull through some of the tools that we've got in our toolkit from the Futures webpage and the toolkit itself to help stimulate thoughts on taking this learning to the next level. But I really want to thank all of the speakers today. It's been a really, really lovely, interesting, informative webinar. And yes, we will be sending the recording out. And as I said, it's on our YouTube channel. And I'll endeavour to try and get the slides to people. I am a bit behind on my admin. It's just me that's sort of trying to do the admin, so I do apologise if you haven't had all the last presentations, but I'll try and pop them all in one email to everybody. But please promote these webinars to your colleagues, and let's try and embed that culture of research. And Chris is going to give us some really good ending final words.
What I was going to say was, Nicola, thank you to you on behalf of all of us, because you are the driving force behind this. And we know that you're busy and you're doing this in your sort of spare time. You know, this is amazing. You've driven it through, you've brought us along. So a huge thank you. You're having a great impact leading this network, and yeah, carry on the good work. We're right behind you, but please carry on leading.
Thanks, Chris. We've got another hand up. Deirdre, is it? Can't quite see.
That was a random hand. Sorry about that. But well done. Really enjoyed it. My first meeting, so thank you.
Oh, brilliant. Thank you very much for joining us. And we'll hopefully see you all again in 1 month's time. Have a good evening. Thank you. And if anybody does want to do the survey on the webinar, there's that QR code there. You can scan it and let us know what you think of us.
Thanks very
much. See you in a month. Thank you.
Thank you.
Bye.
Bye.
Thank you.